to here is considered success, but I think the ideal is an intact sensation with pain-free. So come to the ideal procedure. Long-term effect, intact sensation, low risk or low cost. I believe everybody agree that the microvascular decompression treatment is actually a gold standard, but we need to choose the patient which one actually is actually fit for the surgery. Even the WIP journal also say the same thing. Cost. We all know that the cost is cheap, the lowest for percutaneous procedure. Okay, now the thing is, what to do now? Should we go for ablative procedure in the very beginning? If fail, come down to nerve preservation procedure. For me, I will believe that we need to preserve before damage. If you want to damage, then don't go back to the nerve preservation because they cause a neuropathic pain secondary to intentional injury. Okay, for me, first thing you need to rule out the red flag condition. By IHS criteria, diagnose the classic trigeminal neuralgia. Sorry. Okay, normally we use MRI to diagnose any neurovascular complex. After there's a neurovascular complex, so how come? Then I will suggest the patient two options, either percutaneous or open surgery. And depending also the low risk of GA, young, and the patient is consented. Some patients prefer no surgery. If there's no neurovascular complex, then I don't agree to go for open surgery. This is a patient, is a lady having a trigeminal neuralgia, history like that, but they don't have a first attack very intense. And in the MRI doesn't show any neurovascular complex. So this is a patient with no neurovascular complex. Ultimately, I suggest maybe we get the block to the trigeminal nerve and we see how much relief you have. You have good relief, then we go for percutaneous procedure. This is I think this picture is just a percutaneous. This is another person having a very ectatic vertebral artery go up to the dorsal root entry zone of the trigeminal nerve and compress and cause the pain.
Please finish your lecture.
Yeah, another one slide. Yeah, one or two slides after that conclusion. Yeah. So this is a surgery. Yeah, this is surgery. You can see how bad is the nerve get compressed by the vertebral artery. This is a superior cerebellar artery. This is a ICA. And by putting the Teflon in between the nerve, then the pain will disappear and immediately post-op. This is the area we put the Teflon in. So it actually is no bleeding. And we come to the conclusion. Okay, if the neurovascular complex is present, I believe MVD is the best option depending on the patient condition. So balloon, sometimes people prefer when V1 is involved. And in the individual branch, we choose radio frequency. If there's other cause like multiple sclerosis, that means percutaneous interventional is actually preferred. The most important thing is what is the best option for patient, and the patient normally need to know very clearly. This is my always last slide. When there's no brain, we don't have pain. Thank you.
Thank you, sir. It's an extensive lecture on interventional management of trigeminal neuralgia. Thank you, sir. Our next speaker is Dr. Subrata Ray, consultant of Pain Clinic at KPC Medical College, Kolkata. He will be speaking on cervicogenic headache.
Respected Chairperson, good afternoon to everybody. I will try to compensate the all extra time taken by my previous speakers and try to relieve your headache, because I think some of you are already thinking for having paracetamol. Anyway, though Dr. Arun has rightly asked why we have been called for talking on headaches, because it is a subject of neurologist. But this cervicogenic headache, for a long time, neurologists never recognized that this kind of entity exists at all. Because in most of the primary headaches, they have neck pain. As Dr. Karthik has discussed about migraine, there are some studies, almost 75% of migrainias, they have pain in their neck muscles, restricted neck movements. Other primary headaches also have neck movements. But this is the reverse one. Cervicogenic headache is a headache where the cause lies in the neck. It is a pain referred to the head from a source in the cervical spine, and the International Headache Society has recognized this to be an entity. According to the last classification of International Headache Society classification published in 2013, there are 3 beta version. The description of cervicogenic headache was like, it is caused by a disorder of the cervical spine, and it is a component bony or disc or soft tissue elements, usually but not invariably accompanied by neck pain. The prevalence of cervicogenic headache in general population is quite low. It is 1 to 4.1%. But when you come to talk about patients who are having moderate to severe headache, the incidence increases to 17.5%. And it has been seen that patients who have headache following whiplash injury, the incidence of cervicogenic headache is quite high. It is 53%. Now, how to diagnose this cervicogenic headache? There are 2 schools. There was rather 2 schools. One school belonging to most of the European countries, they depended on clinical diagnosis, and even there was a special group for cervical headache study, and they have laid down some guidelines for clinical syndrome, sign and symptom, how you can diagnose the headache, and they depended mainly on this clinical diagnosis. And there are other groups who are mainly in Australia and North America, who mainly depend on interventional diagnosis for diagnosing cervicogenic headache. And when neurologists are not recognizing this to be a separate entity, the pain physicians, especially the interventional pain physicians, they are trying to push it, squeeze it into the classification, because they have the most of scopes of intervention in this type of headaches only. But ultimately, the International Headache Society has accepted this, and they have tried to take common features from all these 2 groups, and they have combined both clinical and interventional procedures for diagnosing headache. According to the latest diagnostic criteria, in the 3